All right, welcome everyone to another edition of Three Plastic Surgeons and a fourth. As always, I'm Sam Jejurikar in Dallas, Texas, and I'm joined by Dr. Lawrence Tong at Yorkville Plastic Surgeon in Toronto, Ontario, by Dr. Sal Pacella at San Diego Plastic Surgeon in La Jolla, California, and Dr. Sam Rhee at Bergen Cosmetic in Paramus, New Jersey. Welcome, gentlemen. Today we're going to talk about a topic that we don't find that interesting, but I think patients will, and that is how to manage some common complications after eyelid surgery. Eyelid surgery is incredibly common. Complications, at least transient ones, are pretty common as well. And luckily, we have some experts here who can kind of provide some illumination to our patients about how to deal with these. So before we get going into the meat of this, Dr. Tong, you want to read our usual disclaimer?
I sure will. So this show is for information purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something on this show.
So we have talked about this topic before, and Dr. Pacella, in a previous iteration of the show, when Dr. Pacella actually gave us this PowerPoint presentation, but he showed us some pretty severe complications at that point. Kind of the impetus behind all of our topics are things that are happening in our practice. And in the last couple of weeks, I've had a few patients who have done facelifts and eyelid surgery on, and they've had some complaints afterwards. And one of the patients that has been struggling the most was telling me immediately after surgery that her vision was blurry, which I assured her I thought was normal. And then over sort of the first week after surgery as well, her vision was blurry as well. And she was very concerned she was going to lose her vision. Do you guys find that this is a common complication after eyelid surgery, blurry vision? And if so, what are the causes behind it?
Yep. So first of all, I think we have to kind of separate the upper lid from the lower lid. I think most of us on the podcast here and most plastic surgeons will kind of agree that upper lid surgery is a much easier phenomenon than lower lid surgery, really associated with minimal complications, minimal risk, minimal recovery, a little bit of bruising perhaps. Lower lid surgery is really oftentimes the issue with patients when they complain of significant complications, dry eye, pain, discomfort, swelling, blurry vision, etc. So in your particular patient, Sam, was it a lower left or?
It was an upper and a lower left, and I'll just cut to the chase. She had lubricant in her eye right after surgery, which we used to keep the eye. So 100% of my patients typically wake up with blurry vision because of the lubricants that we use to keep their eyes dry.
Absolutely.
But she also had lower eyelid surgery, and I think that segues into sort of the more delayed blurriness we were seeing as well. But it was lower eyelid surgery with a transconjunctival approach and removals with that kind of stuff.
And so, if you look at the anatomy of the eyelid, the inner lining of the eye is in continuity with the lid, as well as the sclera, the white of the eye, or the cornea, which is the center of vision portion of the eye. So anytime you have swelling in and around the eyelid or the periorbital area, that's going to lead to some swelling of the sclera, the white of the eye, and the conjunctiva. Okay. It's all anatomically based. And so I try to do my best before surgery to prepare patients for blurriness and vision issues afterwards, which invariably are transient. But the key is really control of the swelling, in my opinion. So we're really pretty aggressive with compression and ice after surgery. I think one of the sort of factors that can occur after lower lid surgery in particular is the eyelid not closing. And so when the eyelid doesn't close exactly right, and that's transient, that can lead to the eye drying out, which can lead to visual changes and blurring. So something we call chemosis. And so to me, the best way to control that is on the table during the surgery and immediately after. I oftentimes put a little stitch at the very corner of the eye. It's called a frost suture. And to do that, it's very easy to do. It comes out about a week later and it closes about a third of the eye. Now patients can still read, they can still do things centrally. But where you're going to see that that desiccation is really laterally like this. So I put a little stitch at the very corner, and that usually helps to prevent some blurriness, some desiccation. But I think the blurriness is a necessary evil after surgery. So we just got to prepare our patients for that.
Have you ever seen that? Go ahead.
Oh, just to elaborate on the point with the frost stitch, I think that is an excellent practice, and I do that for all my patients as well. I think that it does two main things. One, it prevents the lid from getting pulled down, because even if you're pretty conservative with removing skin and you're doing things to tighten the tone, just the swelling of the surgery itself can cause the lid to get pulled down. And what I find that once the lid gets pulled down, then it can take a long time to come back up. It's transient, but sometimes it can take a while. And the other thing is that then the lid isn't opposed to the globe anymore, and you're going to get things dried out. So that contributes to it. And plus, if you put the frost stitch and have it up like that, that means that that area is always closed. So during that healing process, it's always going to stay moist, and you're not going to get that chemosis, which is the swelling of the white part of the eye, because the chemosis itself can worsen things. The chemosis is basically looks like a clear jelly on the white part of the eye, and that physically being there is going to push the lid out and further cause worsening of that problem. So I think that Dr. Pacella is exactly correct. Trying to prevent that vicious cycle from happening is very important. Sorry, Sam, go ahead.
Oh, have you ever seen that movie Shallow Hal? There's a sequence where the guy goes to the door and he doesn't want to be seen, so he freaking puts all this like petroleum jelly over his face, and it looks like he has this like horrible conjunctivitis. Like when my patients leave, they got a crap load of stuff, of product on their eyes. It's a lot, and I make sure that I provide them with a ton of stuff to keep those eyes lubricated. And I think most of what we're all talking about is what we want our patients: avoid dryness, cover the eyes, know that you are going to be blurry. Let me flip it. I've never had a patient who did not report their vision was clear as a bell initially after surgery or for some time after surgery. They all expect it, as you said. Like we tell them, don't worry if your vision is blurry. Now there are, and we all know about this, reasons why patients' vision can be blurry or they can have issues afterwards. But those are some major issues if you've dinged one of the eye muscles or something like that. Like these are all things that we've learned about. And when you do your anatomic dissections and when you learn about how to do a blepharoplasty, you know what are the things that could be a problem. And I would imagine some of our patients have probably read up on this stuff, started freaking out, and just like everything else, started being a little bit overly concerned. But I think for most of us as surgeons, we examine our patients pretty carefully. If everything looks like it's healing well, if there are no issues, then that blurriness is completely expected. It is part of the normal recovery process. Does that mean that we ignore our patients and never just poo-poo it? No, we're always checking our patients. But I think our patients should know that if they have blurriness after a lower lid blepharoplasty, especially, even at, that's to be expected.
If you've ever sprained your ankle, right? What do the ER docs or the orthopedic surgeons tell you to do? They tell you to put rice on it, right? Not rice in the true sense, but RICE, right? So rest, ice, compression, elevation, right? So rest. I tell this for eyelid patients as well. Rest. You have to rest your eyes. You can't, this is not a time to watch Netflix and chill. Okay. This is not a time to be scrolling on the.
Well, just Netflix, so.
Netflix and chill. That's a
different thing.
I think you're going for.
Not a time to be scrolling, and, doing all sorts of Insta stuff, on the gram. Okay. You got to rest your eyes. Okay. You can't really work and cause eye fatigue. That's going to cause you much more problems. Ice, okay, liberal ice. So unlike, say, when you're icing your wrist, where it's 20 minutes on, 20 minutes off, I'm under the impression you can kind of keep ice on it continuously. Ice, unless it's, some massively frozen ice, little chunks of ice are gonna get warm after 20 minutes anyway. So you got to keep replenishing the ice on the eye. Compression.
And for how long do you tell your patients to ice for?
At least 2 weeks, 2 weeks. I think it's important because you still have swelling. Compression. So sleeping with an eye mask. Oftentimes in the worst of patients that have very prominent eyes, I recommend putting liberal amounts of ointment on, putting an eye mask over, and then actually wrapping an ace bandage around their head. I do that anyway, so I don't have to hear anybody, while I'm going to sleep.
Yeah, are you talking like a sleep mask or something special for blepharoplasty?
Just a sleep mask, like you get on, an Emirates flight. Yeah. So, and so that sleep mask and the compression really help to, I think, add physical compression, which can assist with generalized swelling of the lid and can also assist with chemosis, right? And then finally, elevation. You don't want to lay flat. Obviously, that's going to cause your eye to sort of take in a lot more swelling. You're trying to have them to sleep with their head elevated.
So we've used the term chemosis at least 3 times now. When do you guys want to explain what chemosis is? I know, Pacella, I think you've written a paper that I've read several times on this for management of it, because chemosis is one of the things where if it gets kind of severe for a patient, it can be kind of a pain to get rid of. And so what is chemosis? How serious is it? And how can a patient get rid of it, or a surgeon get rid of it if their patient has it?
So it's a very common complication after eyelid surgery, specifically lower eyelid surgery. Okay. And as I mentioned earlier, the lower eyelid is connected to the conjunctiva of the eye. Or the sclera. Okay. The conjunctiva is a small little membrane on the surface of the white of the eye. When I say the sclera, I mean the white of the eye. Okay. And so what chemosis looks like, it looks like a blister associated with the white of the eye. It's usually on the outside of the eye. Okay. And that blister is inflamed, desiccated, dried out eye tissue. Okay. And why that's important is when the eyes get too dry, and you develop chemosis, the eyelid is not going to close it. If you're closing an eyelid over a globe like this and it's very smooth, that's fantastic. But if you got a bulb of blister right here, all of a sudden that eyelid's not going to close. So chemosis is really and sort of a vicious cycle of eye dryness, which causes the eye to stay open, which causes more dryness, right? So that's why it's such a pain to manage. So the key is really managing the eyelid closure as aggressively as possible, even on the day of surgery. Now, how we do that? We mentioned about the frost suture. How do we control for chemosis in the early post-operative period? Well, so again, rest, ice, compression, elevation. If somebody comes in, they still have chemosis a few days after surgery, I am very liberal with ocular decongestants. Okay. So much like you can put Afrin inside your nose if you have a swollen eye, they make prescribed medications that you can use for eye redness, or Visine, right? For example, Visine works very well for chemosis because it constricts blood vessels, causes an overall reduction in the amount of tissue that's exposed. So that can be utilized very well. That with steroid drops, steroid ointments can usually keep chemosis under control. But the key is, once you recognize it, you got to get it under control, or else it's going to be a problem for weeks and weeks and weeks. And your patients will hate you.
What about a role for mechanical decompression? I know you've taught me about that in the past.
So a little bit controversial. Okay. My very good friend, who's one of the top oculoplastic surgeons in the world, Mo Al Ghul, was in Chicago and is now in Amman, Jordan. He's a big proponent of, if you develop chemosis on the table during the surgery, to do an immediate, what's called a conjunctotomy. So not for the faint of heart, but you can actually lift up that tissue and just trim it in order to get it under control so that it doesn't become a problem post-operatively. Okay. I am not that aggressive with treatment on the table, because I think with just simple compression and closing the eyelid, early onset chemosis can be managed very easily with just eyelid closure. So I would only resect the tissue or remove it probably after about 3 to 4 weeks if it looks like it's not improving substantially. Now, that can be done relatively easily in the office. You just numb it up with a little local anesthesia, protect the eyelid, protect the eyeball, and you can trim it with a tiny little scissor. But that can also cause more dryness and more desiccation and more swelling. So it's a little bit of a controversial procedure.
What are
Sal,
the routine?
do you,
Sorry, go ahead.
I was going to say, do you routinely prescribe steroids?
I usually do it within the context of the ointment. Okay. So everyone that I operate on for lower lid surgery gets a combination of a dexamethasone ointment with an antibiotic in it. Okay. The common
Like a
one that everybody
Tobradex or
uses
something like
is
that?
Tobradex, but Tobradex is very expensive. It's a few $100s for a tiny little tube. I use Maxitrol, which is,
Yeah.
I think, $30 a tube, which is the generic component of things. A lot easier financially for patients. So I routinely have them use that for the first 6 days after surgery. Now, the thing you want to keep in mind here is you don't want to use a steroid for more than a max a week after surgery, but because that can put you at risk for glaucoma.
Yeah, I use it for about a week, but I use both the drops and the ointment usually, and then I for about a week. Yeah, Maxitrol.
What about, is there any role for taping? Do you use taping when they've developed chemosis?
Yeah, so excellent question. So in any lower eyelid surgery, in addition to the frost suture, I use tape, and I usually use very thin foam tape. So the way I put this on patients is I do kind of like a little mask, if you will. All right. So take a thin little piece, about 5 millimeters width, a couple centimeters thick. And then I'll start it from the medial canthus and then place it to the lateral canthus. But it always peels off at the side. So then I put a piece across here and I put a piece across the nose. So that essentially creates a little bit of a sling for the tape. Okay. I usually leave that on at least a week, take it off when I take off the frost suture. If it's a super aggressive lower blepharoplasty that I did, meaning a skin muscle flap, I'll have them taped for the next couple weeks. If it's just a simple transconjunctival blepharoplasty I did, I usually see how they look right the week after surgery. If the swelling's under pretty good control, I don't have them taped necessarily. So taping, I think, is key.
And that leads naturally to yet another complication we can see after lower eyelid surgery, and that's lid malposition. So let's say your patient doesn't have dry eye, doesn't have chemosis, but you mentioned doing an aggressive operation. Why are you having them taped for the period of time that you are? Can you explain to the patient sort of what it is you're concerned about lower eyelid malposition?
So in the lower eyelid, they're small procedures give small results. Big procedures sometimes give big results and great results, in my opinion. So when we're doing a more aggressive blepharoplasty, for example, someone has deep set bags or malar bags. Okay. I think we talked about malar bags on a previous episode. I'm going to do an aggressive lower blepharoplasty on them. The simple fact of the matter is when you do that, you are causing a lot of damage. You are causing a lot of damage to the muscle of the eye that's responsible for closing the eye. So you want to treat the muscle with respect. Okay. You want to give it all the support it needs to continue to close the eye. Okay. And so that's why I use tape aggressively. I use the frost suture aggressively. And I'll have them massage afterwards to help hold the lid position upwards to prevent early onset scarring.
Yeah, another very basic point is, don't go too crazy with your skin removal. I mean, that's probably the number one cause of lid malposition is when surgeons are doing these lower lid blepharoplasties and on the table, it looks like you can remove a lot of skin. And that's only going to give you problems. So be conservative in the skin removal. And I think I know how Dr. Pacella does his blepharoplasties, where when you tighten the skin, you're actually shifting a lot of things laterally as opposed to vertically, so that you don't have to remove skin. You can just tighten things by shifting things laterally instead of vertically. So the amount of skin that you remove is only going to be a few millimeters. 1 to 3 millimeters is my sort of average amount. And then plus the other things that Dr. Pacella had said, reinforce the tone of the lid, either by doing something called a muscle sling or a cantopexy or a cantoplasty, all those things to support the lid tone anatomically. And then the other sort of external things such as the taping and the frost stitch are all sort of working together to prevent lid malposition.
I think providing that lower lid support is the difference between how to do a good blepharoplasty and not. Like once I figured out how to really support that lower lid, Dr. Kodner, huge proponent of many of his techniques I still follow from his videos. That just made all the difference for me in terms of lid position.
Agree. Well, any other complications you guys think we should touch upon for our viewers?
I just think the swelling part, you have to counsel these patients. It's going to take a long time. And I just had a patient. It almost took she's a young patient, like almost 3 to 4 months before it really got to a point where she was really happy with the swelling. And seeing that patient regularly, sort of counseling them through that, it was a challenge. And I feel like some of the younger patients seem to have more swelling than the older patients sometimes. And it's just to get them through that part of it has always been a challenge.
Yeah, and I agree with you. I think, setting expectations for patients is critical. Any lower blepharoplasty, I tell them 3 months at the minimum before you even look like you're going to look normal, near normal, So what I'd suggest to them is, get some cheater glasses, with big sort of, more the type of Smith glasses with the big side things, the Ray-Bans or Wayfarers. And, you wear them to work or, you wear them socially. Oh, I got some allergies to my eyes. They're a little swollen. They usually can hide things after a couple of weeks,
Yeah, I think that's true. When you say it was almost 3 or 4 months for your patient, that sounds pretty good to me, actually, for lower eyelid surgery, Sam. So I've had multiple patients take 6 or 8 months, and it's a long 6 or 8 months for both the patient and the surgeon.
Mm-hmm.
Well, good. I think this has been, these are things that we deal with all the time in our own practice. We talk to people about them on a near daily basis, but I think it's great for patients to hear about this. So as always, guys, great podcast. And until next time.